Good morning, good afternoon, and good evening. On behalf of Cadwell, I extend a warm welcome to our second webinar of 2024. Whether you're joining us from the United States or abroad, we appreciate your presence today. Before we dive into today's session, I encourage you to explore our Cadwell website for up-and-coming events. We're diligently planning the next physician and technologist-focused courses, as well as additional webinars. So stay tuned for the release of those dates and future details. Now let's express our gratitude. A big thank you to Christina Nelson, Abe Gardner, and the entire Cadwell marketing team for orchestrating today's event. Their dedication ensures that we continue to deliver valuable content to our community. Without further delay, allow me to introduce our esteemed speaker, Dr. Jeffrey Strakowski. Dr. Strakowski is a physiatrist based in Dublin, Ohio, with affiliations to Ohio Health Grant Medical Center and Ohio Health Riverside Methodist Hospital. His impressive background includes a medical degree from the University School of Medicine, the Indiana University School of Medicine, residency training in physical medicine and rehabilitation at The Ohio State University, experience for over 20 years in practice. Dr. Strakowski's expertise extends across several domains. He is board certified in physical medicine and rehabilitation. His subspecialty certifications are neuromuscular medicine, sports medicine, spinal cord injury, and pain management. Additional certifications through the ABEM, certified in electrodiagnostic medicine, ARDMS, certified in musculoskeletal ultrasound, and a member of the AANEM Ultrasound Task Force. His contributions to the field include multiple publications on electrodiagnostic medicine and high-frequency ultrasound. Notably, he has authored textbooks such as The Ultrasound Evaluation of Focal Neuropathies, Correlation with Electrodiagnosis, and Musculoskeletal Ultrasound Getting Started. Dr. Strakowski also serves as a MSKUS instructor for Gulf Coast Ultrasound Institute and AANEM. Let's give a warm virtual applause and welcome Dr. Strakowski to today's webinar. Dr. Strakowski, if you'd like to begin your presentation.
Thanks, Mary. Appreciate it. And I'm going to apologize in advance because I have a bit of a cough, so I'm fighting that off. So if I start coughing, I'm sorry. So we got off kilter as we were practicing. Okay, here we go. And we're going to generate questions as we go. So we'll stop at certain points, and if there are a lot of questions, we can stop at certain segments and we'll talk about them. So I know the title talks about new innovations. I'm going to really predominantly focus on the value of combining neuromuscular ultrasound with electrodiagnosis and show some scenarios in which that is helpful. Mary mentioned some of the books and some educational materials that we've created, and including a book in that and some peripheral nerve ultrasound videos. There's a new book coming out, Dr. Kimura's EMG book, that we're all excited about as well. So this is going to be a state of the art for electrodiagnosis. So that's coming very soon. Okay, so goals of this presentation: I want to review the relative strengths and weaknesses of electrophysiologic and sonographic assessment and think about how we put those together and using them in combination, and some imaging techniques to help facilitate that and improve, and some cases combining them both. So I like this slide. If one of the disadvantages when we do these virtual talks is I can't get a real sense of actually who's listening. And I know some of you are beginners, some of you are probably experienced. Some of the people are trying to decide, is this for me? And one of the things, why do we think about adding ultrasound to neuromuscular assessments? And if we're EMGers, well, it's a nice portable tool. Okay, it's different than sending somebody off for an MRI. We have it right there in the spot. There's a really progressive technology, and that means that these images, and I'm going to talk about some of these innovations, have really progressed over time. What you'll find is there's a great deal of patient satisfaction when you add ultrasound to your clinical assessment. And most people don't really understand what you saw in EMG. You can explain it to them in some extent. When you can actually see the structures and the patients see them, you won't believe the amount of satisfaction they have when you're there demonstrating that to them. just learning anatomy is also a nice thing. I always thought I knew anatomy very well before I started doing ultrasound. And then when you have to start kind of combining these two-dimensional images into 3D in your brain, you really get a new appreciation of it, and that's a nice bonus. And it really promotes musculoskeletal and neuromuscular care, and we get a lot of referrals from really all over because of what ultrasound adds, and most importantly, improves patient care. And I'll try to give you some examples of that. So what are some advantages of musculoskeletal and neuromuscular ultrasound? And this is mainly compared to other soft tissue imaging. Well, it's quite a bit less expensive than MRI and some other soft tissue type imaging. And it may surprise some of you to know that it's actually better soft tissue differentiation and spatial resolution than MRI. So we can see smaller objects, and we can see objects in more detail, and anatomic structures in more detail. And conventional MRI is roughly in the realm of spatial resolution of 450 microns. And so this doesn't talk about 7 Tesla, which isn't as available. But conventional MRI, that's about where it is, where conventional ultrasound is down to 150 microns. So really 3 times the spatial resolution by most ultrasound instruments compared to MRI. And I'm going to show you some images of that. And we, this is to talk a little bit about innovation. So some of this ultra high frequency images can get down to 30 microns, and this is pretty exciting from the standpoint that this is the first time in human history we can look microscopically in human tissue without altering it. Okay, so it's very exciting innovation. Okay, another thing that's an advantage is we can provide a focused evaluation. Okay, we don't have to just set up a imaging protocol and then see what comes back. We can ask specifically for what we need, and we can do what we need. It has dynamic capabilities too, and this means 2 things to me when I say it's a dynamic assessment. Number 1, we can see things move. Okay, and that's an area of innovation that's going to get greater and greater, seeing what happens to structures and nerve entrapments and things like that with dynamic movement of tissue. The other thing dynamic about it is, just like electrodiagnosis, we can change what we're doing on the spot. So if we see things that we weren't expecting, we can advance or progress with the evaluation, or do other areas, do side-to-side comparisons, which is really nice compared to other types of imaging. And we don't have some of the limitations like claustrophobia, implants, pacemakers. The patients really like it a lot better. So that's a really, hopefully that gives you a sense of why it's valuable compared to other types of soft tissue imaging. So now we're going to combine ultrasound EMG. Why is that helpful? And this irritates some of the pure EMGers, but this is the progression of technology of EDX for the most part from 1990 to 2024. And now some of the Cadwell folks will say, well, look at some of what we've done with the software, and it's actually pretty amazing for looking at this. But the technology, kind of get the sense of what we're looking at. Let's contrast ultrasound from 1990 to 2024 in that same time frame. And we went from kind of a gray blob where we could see things move a little bit to the point where you can get family photos in utero. Okay, so the technology has been just massive, and the things that we can do with it have just been exponential in just the past few years. And this is just kind of citing a paper that Francis Walker led. I was part of helping write this up, and basically we had come to the conclusion with a number of people that do this all over the world that we should no longer even consider this a separate thing. We think it's so well integrated that we should just think EMG, nerve conduction, and ultrasound instead of getting separate approvals, things like that. We should really just have it available and make it part of the assessment. It's just really important in anatomy. So when we're talking about focal neuropathies, these are some goals that I have. I think everyone would agree that we want to identify the abnormality when it's present. We want to localize the lesion to the extent possible. We want to qualify the relative severity, and we want to identify the cause of the neuropathy and potentially treatable factors. So both ultrasound and EDX work pretty well for these first 3. EDX doesn't help us quite as much for this last one, and that's a really valuable facet of it. And one thing when we're looking at neuropathies, so there's really 3 things that can happen to a nerve. Okay, you can have slowed axons, which has really probably the least amount of clinical importance, even though we seem to emphasize that on most of our research, because it's easy to monitor, easy to follow. But axons block and axons can die. And demonstrating those components of a neuropathy are very critical for having expectations of how to treat it and relative prognosis. And I like this slide because it's just to say that just like the shark and the diver, EDX and ultrasound can work together really well. One's a physiologic assessment, one's an anatomic assessment primarily, and those work really well together. And here's an example of using both at once. So these are a couple of my residents here. The doctors Grant, they're both Dr. Grant, and um, having both things available at once allow us to see the anatomic source of what we're doing, and this is really great for chemodenervation and other interventions, but also even challenging muscles or post-traumatic muscles or something's been surgically altered. Having those available to do at the same time, it can be really valuable. With some strength of EDX, and most of you probably on the call here are already familiar with this, and it's a single reliable testing modality for peripheral nerve function, and it's highly sensitive for many nerves. Can assess nerve conduction slowing, conduction block, and axonal loss, which I mentioned are things that we find important, and probably better than anything in terms of a focal neuropathy. If someone asks you what's the importance of EMG, even if we already know what's wrong, it can distinguish neuropraxia from axonotmesis if we stimulate both sides of the lesion. And there's very little that can do that for us, even clinically, right? Unless we have muscle atrophy, then we know it's fairly severe. But a really advanced neuropraxic lesion can have complete sensory loss and complete loss of motor function. So that's really a valuable tool for us to determine the relative severity. Some weaknesses, well, it's user dependent. Just like most things, if the person's not very well trained or not really skilled at it, that we don't get very good results. Unfortunately, even to this day, some of the techniques, values, interpretation are often not standardized. And so what a lot of my referring surgeons complain about by getting EMGs from um, different practitioners, and they said they're all different. You have to understand some temporal changes and what happens, after acute injury and or acute onset of a problem. It doesn't provide the anatomic correlation of the source of the neuropathy like imaging does, and it really can't distinguish a complete axonotmesis from a neurotmesis, and sometimes that's important in trauma. So what are some strengths of ultrasound? Well, it provides anatomic correlation in focal neuropathies, in some situations insight towards the source. That can be very valuable. Can actually improve our localization. I mentioned how high a resolution ultrasound is, and so we can find localize things down to portions of millimeters sometimes. Does not necessitate waiting acute injury. We can use it right off the bat after trauma, and it actually can be used to distinguish complete axonotmesis from neurotmesis, and it's not painful. So that's another nice thing in patients like. And this is really the same thing that I just showed you. Some of the advantages versus other imaging. And some weaknesses of ultrasound, though, just like any modality is not perfect, it's user dependent, just like EDX. So if the person's not highly trained, we're probably not going to get great results. It's not as standardized, and it's a newer application of the technology. It's getting more and more standardized to some extent, but that's still a problem. It provides a little physiologic assessment. There's some elements of ultrasound that provide that, but not like EDX. And does generally less than EDX, it assess relative severity. Okay. But we do have some tools where it helps us. And it's generally less than EDX to identify a more generalized process with the same acumen. So generalized neuropathies, myopathies, there's greater specificity with electrodiagnosis as a general rule, but there's exceptions to all those rules. Some other weaknesses, so it's difficult to evaluate large fields, doesn't penetrate bone, so it's not really great for spine. And so the higher the BMI, sometimes the less resolution. Okay. So I'm going to get into the Seton classification, and most of you are familiar with that. So neuropraxia, axonotmesis, and neurotmesis, and most people use that. And we know that stimulating both sides of the lesion, we can distinguish that relatively well if we have that capability to do that. And stimulate distal lesion, a neuropraxic lesion, we're going to have a normal response, but we may have a complete block here. So that's a complete neurotmesis. if we have a lower sensory or mixed nerve or motor response distal to our stimulation, that means we have some wall area degeneration and some axonal loss. Okay, so here is a nice view of some of the structural element of a demyelinating lesion, one with some axonal injury and a complete neuromesis. So how do we see this on ultrasound? Well, I thought this dessert looked a little bit like a nerve, so I thought this is a nice demonstration. So this you can pretty much concludes a neuropraxic lesion, kind of looks a bit like the thing we have here, where we see some crumbs on the menu, but most of it's intact. You can imagine this is more of an axonotmesis, and this is a complete neurotmesis. Michael Cartwright and a group of others have done some studies to show we have really pretty high sensitivity for distinguishing complete neurotmesis and peripheral nerve injuries. Here's an example of a neuropraxic lesion. This is a short axis view of a nerve, and we see the fascicles are all intact, but have very large fascicles. Here's a dynamic where you can move back and forth on it. You'll notice that the area of enlargement, not only does the nerve itself get large, but the fascicles get enlarged, but they're still intact. When there's more axonotmesis, we have a loss of some of these fascicles here, and that means we have actual damage within the intrinsic parts of the nerve. And we like to do a lot of measuring sometimes, and that sort of like nerve conduction velocities doesn't always correlate with how severe it is, but there's often concordance. So sometimes the worst ones are larger, but the biggest element or facet of the internal injury is these fascicles and how they look internally. Now, neuromesis can be complicated, and there's different degrees of that. I'm going to talk a minute about the Sutherland stratification of these types of injuries. And what we can say, this is an actual, this is a diagram that comes from Tennell's original writing that we duplicated. And this one actually is a axonotmesis and is intact, but looks pretty challenging. This one here we know is a complete neurotmesis because the nerve is no longer under tension. So this has no chance to heal, and there's just scar tissue in between. Here's one that's a little more obvious. Here's the normal superficial radial nerve here. Mary, is my arrow showing up okay? Can you see my arrow when I'm pointing?
Yes, we can
Okay,
see it.
thank you. So there's a normal position of it in short axis, and then we scan distally, and we see this big enlargement there. And then if you keep scanning, it kind of disappears. This long axis view gives us a nice image of that terminal neuroma there. So what we would have with electrophysiology is we'd have just an absent response, but here we can localize precisely, and then we can also see the tissue around it that might be affected if we're going to do some kind of intervention. Okay, this might be a good place for me to prevent my cough and ask a couple questions, Mary. If you have a couple.
We have a few questions as of right now. What training and or certification is required or suggested to perform and interpret NEMA studies in a private practice office setting?
Why don't we hit that one at the end when we summarize? That's a good
Okay.
summary. Yeah, that's a
And
good
then
question. Huh?
the next question I do have is also regarding billable. So is this a billable procedure, and what CPT codes are used? Are modifiers needed if billed with NCS and EMG studies? So
The answer is this is very available, and um, in fact, there's a lot of systems now that are combined EMG and ultrasound, and certainly Cadwell is the forefront of that. In terms of the codes, I think we can write those at the end. They're fairly simple, and and most insurance plans where we are in the United States have no problem with doing them. We don't always do EMG and ultrasound on the same day if it's a complicated case, but this is something that everybody can get into, and and I really have been doing this for many years, and I don't have any insurance pushback from it in Ohio where I am. And I did it initially from a few companies when it when we first started it, and they weren't used to anyone doing this, and we started using the codes, and the response was, "Well, you're not a radiologist, you can't use a radiology code." but then we said, okay, well, and then all of your patients will just get MRIs, and they realize what an incredibly difference there is in the price of that, and they all buckled pretty quickly. So I don't seem to have any problems with reimbursement in that regard. So
And we've also attached within the chat, you all can see it. It says ultrasound reference document that will contain CPT codes on there for the billable purpose. And there's also information about the certification listed within that document as well, for physicians.
that's perfect. And we can do at the end if you want to throw that up there. I can talk about those codes in more detail. I don't have a slide for that though.
Okay.
All right, we'll move forward here now. So imaging peripheral nerve. Thanks, Mary. We're going to what are some things we can do, and what are we looking at? So this is a cross-sectional cartoon of the nerve, and this is kind of the level of that we see. So you know that nerves consist of nerve fibers that are covered by endoneurium, and then those bundles are covered by perineurium. And we talk about the honeycomb pattern of a nerve we see in cross-sectional area. What the honeycomb, what's making that is this level of perineurium and these bundled fibers. So what makes the dark circles or the fascicles that we described are at this level right here. So this is the outer epineurium, and this is the really conspicuous hyperechoic. But when we say hyperechoic, it means bright. Hypoechoic means dark. And this is the part that we measure. So when we measure a nerve, we do the inner border of the outer epineurium because it's very conspicuous. That's why we selected the way to do that. And looking at the fascicles, if there's damage to those, we'll see changes, or they'll coalesce, or changes in these walls. If we see perineurial change and overflow, then we know we have a pretty severe injury, and we have a higher Sunderland level classification. I'll get to that in a second here. So this is another appearance of a nerve. And we see this cross-section area, and a lot of people like to refer it to a honeycomb appearance. And again, these are the fascicles that are sort of surrounded by the connective tissue, which is bright. Okay, and this is another example of short axis. We can see each individual fascicle of the nerve, and a long axis view of a nerve. And we have these unending, sort of, I describe it like railroad tracks. So unlike the intercalated fibular pattern we see in tendons, which here's an overlying tendon, have these unending fascicles there of a peripheral nerve. So this is a really characteristic pattern of a nerve in long axis. Okay, so I mentioned ultra high frequency resolution here. So here's an example of sort of a fibular appearance of the flexor carpi radialis tendon. This is the median nerve, and we can see each individual fascicle. So this is at 48 megahertz, and we can even see the palmar cutaneous branch of the median nerve. As we scan distally, you'll see it go through the compartment of the flexor carpi radialis. So what's nice about this level of resolution is we can see individual fascicle injury and see the structures in great detail. Here's another example of ultra high. So this is the medial plantar nerve, lateral plantar nerve. This is the flexor retinaculum, and Mary's picture is covering my artery, but it's over here somewhere. I presume you guys can see it, and we can see the muscular walls of the artery. Now you'll notice how when you start moving, they're even more conspicuous. And there you can see that artery pulsating. So that's the posterior tibial artery. Deep here that's the flexor hallucis longus tendon right there. And so we can see a lot of extreme detail. Okay, and here's another example. This is the ulnar nerve at the wrist. This is the flexor carpi ulnaris muscle and tendon remnant. With lower frequency, sometimes people get confused. Is this a nerve, or is this the nerve? Or are they both nerves? And because they look very isoechoic or similar, when you're faced with that, you can scan proximally and distally. When you scan proximally in something that's partially tendon, it'll become more muscular and disappear, where the nerve won't. Okay, but again, you can see every individual fascicle of the ulnar nerve, and not only that, as I scan distally here, you'll see the branch from the dorsal branch of the ulnar nerve that innervates the dorsal aspect of the hand come out, and we can count each individual fascicle there, and those usually have about 8 to 9 fascicles in most people. Okay, and this is one, if you guys are live, what I like to do is have people guess what are these nerves here, and unless they've heard my talk before, no one ever gets it. And you can see every individual fascicle and what this is. And this is really just for impact. You can see I'm moving here. this short axis view of two nerves, and they kind of come together, discally and distally and apart. And the answer is this is the medial branch of the deep fibular nerve within the web space of the first toe. So this is the lateral branch of the medial dorsocutaneous nerve, which is a small branch from the superficial fibular nerve. So imagine that we're seeing the medial aspect of the great toe. It's what provides sensation in that web space, and distal branches of that in every individual fascicle of that. And the purpose of showing this is to let you know that there's no nerve that's superficial, no matter how small, that we can't see. That's a large fiber nerve. Okay, so I mentioned Sutherland classification, and that's just a stratification of the different types of axonotmesis. Some people consider it types of neurotmesis, but it's internal neurotmesis, and the neurotmesis is the connective tissue completely absent. So this has no chance to heal, this number 5, without a surgical intervention. And number 4 probably doesn't either. So this, even though there's still connective tissue, these are probably not going to regenerate. The other ones have chances for recovery. So identifying these differences are important. Electrophysiologically, though, most of these will be exactly the same, right? Until we get into the neuropraxic or milder axonotmesis. And so when we get into that, can we see certain things? And the answer is yes with ultrasound. So here's an example of a median nerve. It's fairly subtle, but it was injured, and the radial aspect of the median nerve was all the pathology was. You can see most of these fascicles are normal, but there's some changes here. And remember, things are more conspicuous when they're moving. So I'm going to move a little bit, and you can see the changes in those fascicles there. And so those were selectively injured. And so that level of acumen helps us making clinical decisions of what's really going on. Why are they just having problems in certain areas of the nerve and not others? So for partial fascicular injury, that helps. And also gives us an idea of just the relative severity of anatomically what it looks like. Here's that same nerve with higher frequency now. And this is the area where they're losing some of the fascicular architecture, and it's relatively preserved on the more ulnar aspect of the median nerve. And so what this person had was a lot of numbness at the thumb, and then weakness of the recurrent branch, which was found more distally. Now here's an example of one that's not so subtle, and this was a pretty extreme injury that happened during surgery, and so this is all part of the nerve here, but we have a normal set of fascicles here and completely impaired set here. So even though parts of those facets electrophysiologically may look similar in the two different cases, there's quite a bit of difference in what to expect ultimately for prognosis. Now we're moving the flexor tendons around, and you see the nerves are relatively stuck in the scar. I'll show it again. Okay, and there's a still picture, a little larger. Okay, so I'm going to talk. You want to hit another question or two, Mary?
Absolutely. We have 2 right now. What are
Okay.
the benefits of muscle quantification in ultrasound?
That's where we're going next. So I'm gonna address that question in the next few slides. Wait, make sure I heard the whole thing. What are the
benefits of muscle quantification in ultrasound?
Perfect. Thank you for that
Okay.
question.
And the next one is for median neuropathy. How do you grade mild, moderate, or severe?
Great. So actually, both of those questions tie into the next segment here. So in answer to that second question, it's really not necessarily ordinal by how large the cross-section area is. And it's kind of like a little bit like the analogy of nerve conduction velocities. So a median nerve shouldn't be considered severe just because it has a delayed latency that's extreme. If it has really good amplitudes. Okay, that could be a demyelinating problem usually, but they're concordant. So usually the worst ones are larger, the worst ones are slower. Okay, so that usually goes together. But the elements that we're looking at in that median nerve for severity is part of it. What I showed you, do we see fascicular change internally? And I showed you that the one. I'm going to actually back this way up to answer that question. I'll just go way back here and come back. This one. Okay, so this is a really enlarged median nerve, but what made this one really severe, almost no function, is the loss of these fascicles. So that's one thing that's not easy to qualify in extreme um, detail, but we can tell that this is severe because of the fascial injury. So what we're going to talk about in the next segment here is muscle ecotecture, and that was what the other question was. Okay, because we can use muscle to help distinguish relative severity too. If there's a great deal of denervation, that means we're in a relatively severe category. If the muscle innervated by the nerve we're under concern is still preserved, then we're not. Then we basically conclude that it's in the mild or moderate category with a lot of axonal loss. Okay, qualifying that gets a little harder, and I'm going to talk a little bit about that as I go forward here. But those are the two main things for severity in something like carpal tunnel. Is we're looking at really the muscle ecotecture, number one, as most important, and try to evaluate a little bit internally what the nerve looks like. I still believe that electrophysiology has a better role for the severity, though. Okay, so muscle appearance. This is muscle here, and that's fascia muscle in the yellow arrow. And in short axis, we call this a starry night appearance. It's intervening muscle fibers around the paramecium. Okay, and there's a long axis muscle there, short axis muscle there. And so muscle fibers, unlike tendons, when muscle is sick, it gets brighter because it loses the normal hypoechoic muscle fiber. And so we're left with connective tissue and fatty infiltration. And so in myopathies and neuropathies, if they're severe enough, it'll actually affect the appearance of the muscle. Okay. I just have this slide in there because we generally want the highest frequency we can for peripheral nerves when we're looking at the nerve itself. But with muscle, it's usually better to lower the frequency a little bit to see it more ubiquitously. That was the point of that slide. Now, here's an example of denervation in a severe um, fibular neuropathy. Okay, so this is the anterior lateral compartment of the leg. And so here we see the tibialis anterior muscle in short axis. Here we see the extensor digitorum longus. Deep to that is extensor hallucis longus. And over here is going to be the fibularis longus and brevis. Okay, so this is a normal, healthy muscle that is dark, and we see the normal appearance in our starry night appearance in short axis. This is in the same individual with a pretty bad neuropathy of the fibular nerve, and we can see complete denervation of that. There's still some striations of the muscle, but no one would mistake these being the same or or this being a normal circumstance. Okay, so that's one that can really help us in complicated neuropathies. Now, here's an example of focal denervation. Okay, so here's the pronator teres, and that's normal. So C6-7 pronator teres. Here we have the flexor carpi ulnaris and flexor digitorum profundus, and these are denervated to an extent compared to the normal muscle sitting right next to it. So I usually ask the crowd is, okay, anybody want to make a diagnosis? Most people say that's an ulnar neuropathy, which could be correct, but my question is best answered with a question. Say, well, why don't you show me a few more muscles? That way I know, just like we're doing needle EMG on these. And this actually happens to be a C8 radiculopathy. So if we scan further down in the forearm, we'd see that the pronator quadratus median innervated C8T1 muscle is also denervated. Okay. So, but you can see how having these affected muscle next to a normal muscle really helps us with localization. We want to make sure we've just looked at enough areas. Now, this is a myopathy, so this is somebody with FSH compared to this is I don't know how well you can see my arms here, but I'm not known for being a bodybuilder. Um, but this is my biceps brachii at the same depth, and this is the individual with the myopathy. So, and you'll notice it's a little different than the extreme. Even this is very denervated, but we still see some of the ecotecture here. In advanced myopathy, we kind of lose all that muscle ecotecture, so they're slightly different. Now, I know there's some work being done on even AI instrumentation to try to look at this better than the human brain and distinguishing some of these more subtle changes because they can look at very large numbers of these disease states. And so the technology behind this is going to continue to progress. And I will tell you that this is going to be in your hands too, in some of these portable devices and much sooner than you might realize. So this is really really coming fast. And I know the people working on it. This is an example of looking at normal descending trapezius. This is a descending trapezius and somebody that has a complete spinal accessory neuropathy. So they had a lymph node resection and the nerve was cut. And so this is complete denervation. You notice you can still see some of the striations, but vastly different from the normal muscle. Here is another case of myopathy, and you can see that looks different than the complete denervation one, and with a loss of any of the architecture. But again, with varying degrees of neuropathy, varying degrees of myopathy, you can't always be confident that you're able to make that distinction. Okay. Want to hit another question here?
Absolutely. Is 16 megahertz frequency enough for a good evaluation of fascicles damaged?
And the answer is yes. 16 megahertz is really pretty high. And I do a lot of traveling to places, and I've had some people yell at me. It's like, we can't afford these really expensive, and they're really expensive. Some of these devices, and so what do we do? And the answer is you really can see this pretty well on conventional ultrasound. Um, there's an advantage of seeing some of these images at ultra high because you learn the anatomy a little bit better, distinction. But it's pretty rare that I will make the diagnosis purely on just the ultra high frequency stuff. So you can, excuse me, the answer is you can usually see the fascicles pretty well. So let's go on to um, next part.
We have
So what are
one
the
more
advantages of
question
using- what's
for you.
that?
We have one more question for
Okay,
you.
let's do
Is it
that.
required for EDX to have another degree NEMIS or clinical training and self-learning is enough? So I think it's from one of our international members right now. So I'm trying to kind of answer this the best to my ability. I think what they're wanting to know is there any degree required for doing
The,
NEMIS
the
or
answer
is
is
clinical
no.
training enough?
The answer is no. And some of that is institution specific, and also what country you're in, and your governing bodies and things like that. But the reality is there's not a lot of structure for neuromuscular ultrasound, nor was there even a lot of structure for musculoskeletal ultrasound when I started with that. So most of the people that are advanced in neuromuscular ultrasound, it was fairly self-taught. And so now we have a lot more teaching available for this, which makes it nicer. The AANEM or the ABEM has a neuromuscular ultrasound, as part of the task force that created this exam for an examination to do that, to show you have credentials. So it's a society credential, just like getting board certified in electrodiagnosis is. But in the United States, people that have no specific training in it can still do electrophysiology. And so, you know, certainly encourage the training, but this training for this is not really in most um programs yet. So that shouldn't be a limitation. But there are a lot of courses and um, educational materials now that help you. Most of you have probably read this slide by now. So I'm fighting off my cough really bad here. But it can be used for needle guidance, more precise localization, and can provide information for the anatomic source of the neuropathy. And it's sometimes helpful when electrodiagnostic information is not available, incorrect, or limited. And I'm sure people that do EDX will have patients that have maybe had a bad experience somewhere else, and they're saying, "Well, I'll never do that again." And this is a nice way. In that case, you can get some information without having done that, without having to put them through EDX. You can identify anatomic variations. You can identify dynamic abnormalities. You can identify post-surgical changes and help in neurologic comorbidity, and even musculoskeletal mimics you can identify sometimes. So these are all some value things to help with electrodiagnosis. I'm going to give some examples here. Mention the guided procedures. So Andrea Boone and a number of others have kind of shown that it actually improves accuracy with needle EMG. So it's really nice to have that tool available. Most experienced practitioners don't need it for routine things. Um, People learning EDX, it's a fantastic anatomic tool to make sure you're in the right muscle and learn the anatomy. But there's times even when we're very experienced, for example, we have a serratus anterior um, atrophy and you're concerned about a long thoracic neuropathy. Sometimes it's really hard to find the muscle and get into that, and it's potentially dangerous. There's a number of things where this could be helpful, just having it available to help facilitate and finding challenging nerves sometimes as well, and to determine the location or anatomic variation of those. So it really helps sometimes, even with your just having it available for your EMG. So I give some examples of injections. This is actually a trigger finger injection, so it's a musculoskeletal one, but to show the relative precision. So the idea is to, in this case, I do more than just stick steroid in there. We can actually fenestrate the A1 pulley that's restricting this tendon movement and find the tip of the needle. This is an in-plane view of the needle and do injectate there and with really great precision and not injure any part of the tendon itself and be very close to this constrictive A1 pulley. Here's an example with it moving, and you can see the injectate come out and see the flow of the needle. So really nice for a procedure like that. So we can distend that away. Now here's an example of a carpal tunnel injection. This is kind of blown up with kind of low, kind of older equipment here, but there's the median nerve. And when we can do an injection real precisely, these are the flexor tendons here, and there's the tip of the needle. You notice when I see it move, so I like to get some injectate past the nerve, and then I kind of work my way back out, and we can separate the nerve from the surrounding tissue, and then do the same thing on the superior aspect around the flexor retinaculum up above. Here's an example of a similar injection for the lateral cutaneous nerve of the thigh. So this is the ilioinguinal ligament. There's a cross-section area of an enlarged nerve, and, and you'll notice that I'll put a little bit of injectate around that and adds conspicuity to the edge of that nerve, and then we can do a larger, what we call a hydrodissection or hydrorelease to try to open up space around an area, especially if the post-surgical cases are scarred. We do those for that reason too, so it's a really nice tool for that. One thing that I think is really important, really valuable, are complicated cases in chemodenervation. Because you have the ability now, even on the same screen with some of this equipment, to have both EDX and ultrasound on the same screen. In this case, I don't have the audio with you, but this is an individual that had retropectoral thoracic outlet compression, and due to the pectoralis minor being somewhat spastic and really tight. So the neurovascular structures are underneath, and this wasn't to show the anatomy of that, but here's the needle. And when the needle was moving through the pectoralis major, there was no electrical pattern or interference. And once it hit the pectoralis minor, even in a resting position with the shoulder, we had a full recruitment pattern, and we could see that the needle was precisely in the right place. So here's the tip of the needle. Again, it's more evident when you're moving. And you'll see the injectate going right within the confines of the pec minor, avoiding the neurovascular structures or lung underneath, and not being in the wrong muscle. Show it again. And so it really helps to have both of these together in many situations. I'm going to talk about some case scenarios here. Um, and Mary, we can do questions, or we can keep moving ahead with case scenarios, depending on how many questions you have lined up there.
We have two more for you right now.
Okay,
So
let's do
the
those.
first one is, how useful is NEMUS in evaluating the brachial plexus?
How useful? Okay, you use that abbreviation. The answer is extremely useful. And I mentioned the higher resolution. So if many of you have gotten MRIs for the brachial plexus, it's very unsatisfying sometimes. But we'll move forward. I'll show some images of just to answer that question here.
Okay.
Why don't we do a few case scenarios to answer some of that? So I mentioned more precise localization. Okay, these are some advantages of ultrasound with that. So more precise, it's valuable in non-conventional entrapments that we don't have great electrophysiologic techniques for. It can provide better specificity in conventional entrapments, and it's helpful in the face of potential multiple sites of entrapment that would be really hard to figure out electrophysiologically, or if the wrong fasciculary. So we'll give an example of a non-conventional entrapment. Okay, here's somebody that's having a lot of pain and numbness at the distal foot from a little focal neuroma, digital nerve, and you don't see it in the still image, but you'll see that hypoechoic neuroma pop up right there. Okay, that's just one example, but we don't have a good electrophysiologic technique for that, but we can find it with great precision with ultrasound and not counting on just, well, is it sensitive there? Okay, here's an example of an ulnar nerve that people were struggling to qualify this, what the source of it was, and it was kind of missed. And this is in the forearm here. So there's the ulnar nerve, here's the ulnar artery, and as we start moving, there's a big schwannoma there that was making it technically hard to localize the neuropathy. And then also there was no explanation for that with electrophysiology alone. Here's an example of I got chastised by one of my PM&R um, colleagues who said we should call this residual limb neuroma. So I corrected that on one set of slides. Um, but we can see an area where there's an amputation and we can find the neuroma and follow it back. And it helps us when we don't have electrophysiologic technique for that. It's great in an unusual neuropathy. Okay, we'll get to brachial plexus in a minute, but this is an example of neuralgic amyotrophy where there's partial fascicular involvement. So this clinically looked like a posterior osseous neuropathy where there was just weakness in this individual and digit extension and wrist extension with some radial deviation. Okay, no sensory loss, but the localization of the problem was at the spiral groove. And here we see normal sensory fibers right next to abnormal motor fibers. So these are the fibers for the posterior cutaneous nerve of the forearm and the superficial radial fibers. These are normal and these are vacuolated and abnormal, suggesting an autoimmune source of this neuropathy. But both our clinical and electrophysiology would localize this to a different location without imaging. Okay, there's better specificity in conventional entrapment sites. Okay, so we can inch all day long, but when we um, can actually see the site of the ulnar entrapment, we know down to with great precision where it's affected and where it's not. This is a long axis view of the ulnar nerve at the elbow, and this is the narrowing. And usually in a focal entrapment, we have an enlargement about 1 to 2 centimeters, and most commonly above the level of the entrapment. Okay, this is the median nerve, and we can see the precision of where that's entrapped as well. This is when we show long axis views, the left of the screen is towards proximally, the right of the screen is towards the fingers, and that's the movement, that's the position of the nerve into the carpal tunnel space. These are the flexor tendons. And it's helpful to see both short and long axis. There's a large ulnar nerve in short axis, and we get a greater perspective when we have I put a split screen together to show the whole thing, but we get a real good idea of just how much of that nerve is affected and how much is abnormal. So dynamic view, and we get this will pull up a plexus to that answer. One really great feature of ultrasound is we can see things dynamically. So we can see the posterior labrum of the shoulder, the humeral head, articular cartilage, infraspinatus muscle and tendon, glenoid. So that motion really gives us a lot of information. Specifically for a nerve, here's the ulnar nerve at the elbow, and it's very enlarged, but it also has a significant snap across the elbow. So it subluxes to a complete anterior position and then subluxes back from the anterior position with a rapid snap. You'll see in the process of that too, there's a really irregular medial-epicondyle. That thing's doing funny things with me here, but as it snaps back, it's really irregular there too. And there have been some studies and suggesting maybe a potentially protective mechanism of subluxation. You can be sure that if there's a rapid snap over an irregular surface, though, that's causing attraction neuritis and not helpful. I'm going to skip over some of these here. But another examples of dynamic, here's the median nerve that looks pretty normal in the carpal tunnel space, but they have symptoms of what you see it start moving. There's actually the flexor digitorum superficialis muscle comes into the space. So this may look normal in a static image, but we see what happens dynamically. So they're not always idiopathic as we've previously thought. Here's an example of the brachial plexus, and we can see really detailed look at the brachial plexus. This is a unilateral thoracic outlet entrapment, and we see this bowing of the pectoralis minor over the cords of the brachial plexus. So this is the axillary vein, axillary artery, and this is the lateral, medial, and posterior cords of the brachial plexus. And I think I have some answer the question of relative severity. I'm going to skip over that too, but this is just showing the details of how affected the nerves are can be helpful. We can see down to certain fascicles, so we can identify different parts. This is the fibular nerve at the fibular head. We can see the lateral serocutaneous. We can see the fascicles of the superficial fibular nerve and the fascicles of the deep fibular nerve, and even the articular branch here. So we're able to see all these elements within detail within the same epineurium. So if we have partial fascicular involvement, we have an idea what's going on. Okay, and it can explain a lot of complicated issues. This is muscle localization. Again, this is the interossei. This is somebody that has an ulnar neuropathy at the wrist, and this is the good side, and this is the affected side. And this even helped us here because this is the abductor digiti minimi. This is the fourth dorsal interosseous. And that helps us localize this denervation relatively close to the hook of the hamate, where there's normal or relatively normal abductor digiti minimi and completely denervated fourth dorsal interosseous. Now, for plexus things, we can not only see the images of the nerves, but we can see the muscles themselves too. Again, so this is the supraspinatus muscle here, and normal on this side, abnormal on this side. Helps us for focal neuropathies. I mentioned the serratus anterior. So this is the muscle architecture on the normal serratus anterior. This is somebody that had an EMG elsewhere that insisted that even though the person had mediascapular winging, that this muscle was normal in EMG. They had normal recruitment. And this is the image. And so we know this was completely denervated. So what they probably did is put their needle into the intercostal muscle here. And there's, for perspective, there's lung right below that level. So you can see with ultrasound guidance, that would help us with that technique, but it also very much helps us with a sometimes challenging diagnosis. Okay. And I mentioned I'm going to try to find a plexus injury for you guys. I don't have one here. Oh, there's more. I'm sorry, Mary, I can't find a brachial plexus. There's some tumors. Those are useful. I'm going to try to wrap up here, but I wanted to find somebody a brachial plexus for that question. I don't think I have one. There's some fasciculations, by the way, that somebody had ALS. There's a saphenous or muscle. You can tell I could do this for hours. Oh, here we go. And I'll wrap up with this. So this is a thoracic outlet assessment. Mary, we're going to go over if I touch this. Can we go for a couple minutes here?
We absolutely can.
Okay. I wanted to answer the plexus question at least, and I didn't realize I didn't have any. So why is this complicated? Well, there can be entrapment at the scalenes potentially, costoclavicular, at the retropectoral area, can be all neurogenic, all arterial, all venous, or any combination of those. But we can do a survey and look for different parts of the brachial plexus. So here's a posterior tubercle of the C7 transverse process that's very enlarged. Okay, and here's the middle scalene, anterior scalene. It's a C7. And so this is a predisposition towards thoracic outlet entrapment. Now here's an example of the cord level of the brachial plexus. We can see the axillary artery. We can see the subclavius muscle here, pectoralis major, pectoralis minor, and this is the second rib, and this is the clavicle. So we can see if there's a hypertrophy of subclavius, we can see the pectoralis minor if it's hypertrophied, and there see if there's problems with shoulder abduction. And so we can see the cords there. And I think that's it for brachial plexus here. So I'm going to wrap it up. And
We do have a few questions in the chat. So I'm going to go ahead and, are you able to answer those, Dr. Strakowski?
I'm going to answer them to the best of my ability. I'm just going to get to our final slide here.
Perfect.
So first off, look how happy everybody is using both modalities together. And in conclusion, I pretty much always use ultrasound now.
Perfect. The first question is, hi, any recommended probe frequencies to visualize the needle or any recommended settings?
Okay, so with needle visualization, it really depends on the nature of the depth of your injection. So if you're doing something superficial, forearm, carpal tunnel, high frequency is usually pretty good. Now there's some transducers that have really narrow beams, and some of the compound imaging and things like that. So you have to be careful. But um, most superficial injections, you high frequency is just fine in the realm of you know 8 to 12 centimeters or 12 hertz, excuse me. I'm doing deeper injections, things around hip, even if we do, for example, an injection of the suprascapular nerve, it's down about 4 centimeters in most people. And then using a curvilinear transducer allows you to see the needle better. And so having a lower frequency transducer helps. And especially if you have to do a really steep approach. Okay. Ideally you want to be as perpendicular to the needle as you can to have the best visualization. So it really depends on the depth of your injection is my answer.
Wonderful. And then the next question is, please specify about the HECMAT scale used in muscle dystrophy and Z-score for that.
Okay, so HECMAT scale was something that was Dr. HECMAT introduced way back in the 1980s, and we're kind of working towards getting more sophisticated than that. But it has to do with a 4-point scale where it's roughly how well do you see the bone lined up. Maybe I don't know how to do this. Let's see if I can just get me to a myopathic muscle here or neuropathic, either one. Somewhere I'm talking about muscle. I don't know. This is going to be challenging to. Well, all right. Okay, here we go. These aren't very good examples because this isn't so horribly denervated, but this is a normal muscle. This would be a HECMAT 1, and we can see the real ridge of the bone. When HECMAT 2, it starts getting a little hazier. 3, we can't see the bone ridge very well, and 4 is really denervated or myopathic, and it has to do with the relative image. So it's kind of an ordinal scale. It's a little bit subjective, but 4 is worse. 1 is normal. Okay, and we're working on some systems to define this in a little more detail. Still a nice thing, so we know what we're talking about, though.
And the next question is, Dr. Strakowski, do you use ultrasound routinely for diagnosis of entrapment neuropathy of LFCN?
Mhm.
How can it be useful?
That's a great question, and the answer is resoundingly yes. So the lateral cutaneous nerve of the thigh, um, and we don't like to say lateral femoral cutaneous nerve as much. The anatomists don't prefer that because it's not a branch of the femoral nerve, by the way. And so I like the way you phrased that question. Um, so thought I'd show that while I was talking about it. And so what I imagine that everyone that does electrophysiology finds the challenge of trying to determine if the nerve conduction was helpful or not. Sometimes it's just hard to get, and we could talk about techniques to enhance that, but sometimes it's hard to get, and sometimes the people are relatively obese that have this. With ultrasound, it's fantastic because when it's abnormal, it's really usually notably abnormal, and and so it's not really very subtle most of the time. In a case where it's a lot harder with other things, so we can see an enlargement greater than 2 millimeters squared or so in that range, and you can see some change usually at the ilioinguinal ligament or slightly distal, and sometimes we'll even see that nerve, from hip replacements that have an anterior scar, things like that. So it's really got a lot of value for that, and I find it much more effective than electrophysiology for the most part.
Perfect. One more question. And I think this relates to one of your very first slides. It asked if the two men in the picture were twins. So I think it might be that ultrasound picture.
They're not, but they're brothers. Okay.
Okay.
Oh, I don't know if some of you may know Peter Grant, who is a really well-known. Let's show those guys. Let's see. Made it mostly without coughing a whole lot. So here they are. So these guys are brothers, and they just modeled for me for these pictures. So he's not a real patient. That's why we can show this without the bars over the eyes or whatever. So that's Colin and Grant. And
Did you want to discuss the CPT codes with them? Did you want me to share
sure.
them?
Do you want to throw those up?
I absolutely can.
Yeah. I gotta stop sharing, don't I? Let's see.
I think so. Screen share. Let me pull that up. Can you see it? Dr.
Yes,
Strakowski?
I
Perfect.
do. So this is probably mostly for United States. I don't know if anybody internationally uses any of these. You can comment if you do. But this has a history. So when we started out in musculoskeletal ultrasound years ago, there was a 76880. Oh, you can't see my, I'm sorry, you can't see my cursor here. So one at the top, there was, yeah, you can do it. Thanks. It's 7880 is what it used to be. And then they stratified it from a complete study, 76881, and an income, or excuse me, in a limited study, 76882. So limited study, I think, were overused by neuromuscular folks. And I found it frustrating because it really doesn't pay very much. And a limited study usually means, you're looking at, you might do a carpal tunnel assessment where you just look at the median nerve, circle it, and that's it. Okay, that'd be a limited study. Or you're looking at a cyst or looking at one structure. A complete means you looked at all the different tissue of the joint that are pertinent, where it includes bone, nerve, tendons, things like that. And some of the neuromuscular folks got a little frustrated because these were all based on musculoskeletal criteria, and it didn't really fit for people doing, peripheral neuropathies, myopathies, even focal neuropathies to some extent. And so then a group of folks, I helped start with this, but I had very little to do with it, came up with this code that kind of came to the rescue in the United States, is the 76883. And David Preston led the charge on this. I say this every time I lecture on this. I think we should erect a statue of him for the work he did on this, because this 76883 is, now we have a useful code that actually pays better than the others for neuromuscular ultrasound. And basically the criteria is it's mainly for nerve, not for myopathy. And so you have to kind of look at a nerve to use this. But it sort of details that you have to look at the entire nerve, just not one just segment, which is pretty easy to do. Okay, and it doesn't take a long time to trace the entire course of the nerve. And you have to show at least a real-time image, and also show a cine loop where you have video capabilities, and that's the criteria for using that code. The other ones, the 76942 is something, if you're doing an injection around a needle or a biopsy, you use that code as the guidance. And then some of the others below that are self-explanatory, but most of them have a little to do with ultrasound. Just some of the innovation one.
And then there is one more question in the chat, and it's, hi, can you describe the benefits of muscle quantification?
Well, okay, so muscle quantification, the main benefit is to try to determine if there's a pathologic condition, and it's really important with myopathy, but also neuropathic structures. So I use it all the time in terms of how much relative denervation I believe there is, and sometimes you can do comparisons to other muscles, things like that. So it has value for severity of neuropathies, and has value for localization of neuropathies, and has value for um, muscles, and even muscles that are myopathies that are complex, like IBM, for example, that may have selective forearm abnormalities. You can help identify that quickly. Okay, so that's a big role of qualifying, relative involvement of those. And again, we talked about the HECMAT scale to look at it a little bit. We're trying to come up with new techniques to make that more ordinal and more reproducible between people, different examiners. But that has a lot of value. And even looking at the spontaneous activity, you can identify fasciculations in muscle to a greater extent, really, than even needle. For example, we don't really look at fasciculations with EMG. We look at fasciculation potentials, but we can identify all the actual movement of fasciculations with that imaging. So there's a number of things with muscle that are very helpful. I
Okay.
hope I hope that answered what you're after.
Mhm. And there are just two more questions in the chat, and we're going to cut it off after that. Is that okay, Dr. Strakowski?
If I can last that long with this cough.
Okay. This question you may be or may not be able to answer. It says, can chiropractors do this as well in New Jersey, New York, and PA?
So I don't know who can bill what and who get reimbursed and all of that. And I don't know about different state laws in those areas. However, I will tell you that a number of some of the top musculoskeletal ultrasonographers around were started out as chiropractors, and one of my mentors early on in the musculoskeletal realm was somebody that was a former chiropractor and just dedicated his time to ultrasound. And to this day, I've never found somebody better at it than him. I'll be honest. So
And then,
just clinically amazing. So I think this is something that this is an area that should be considered multidisciplinary. It's a great tool for almost no matter what you do in terms of the reimbursement. That gets into with it, other things that are beyond the scope of what I can tell you. So
and then the last question that we're going to answer for this round is, which code is used if you use ultrasound for just one muscle on EMG?
but that would be a limited code. That would probably be
76882.
yeah, well, it depends. So if you're using it for localization, it would be the localization code. And you may or may not get reimbursed for that. So if you're just using it for a single muscle. But and so you wouldn't want to use a limited diagnostic because you're not, unless you're doing a diagnostic for that.
Perfect.
So if you're doing a diagnostic for the muscle itself, then you could potentially use a limited code.
Perfect. Well, thank you, Dr. Strakowski, for your time today. We hope everyone enjoyed this webinar. You will have ability to watch it and review it in the days to come. Everybody give Dr. Strakowski a big round of applause and thank him for
You guys. I can't see, and sorry about my cough. It's just an asthmatic cough, so I'm not dying over here. I'm fine.
Well, have a wonderful day, everyone. Thank you for your participation.
Thanks, Mary. Thanks,
Thank
Christina.
you. Bye-bye.